Dear friends, today we are going to talk about the chronic stridor. I already talked about the acute stridor, and we almost covered everything about the acute stridor in the last video. But unlike the acute stridor, chronic stridor is a very big topic, and it has a very important causes, particularly the congenital causes. So what I going to do is I am going to give all this in so that I can show some videos also. So among the important causes, I think you all know laryngomalacia ranks number 1 of all chronic stridor. It is also called congenital laryngomalacia, and we are going to talk about that and all. Okay. Right. Before going to stridor, we should know something about the respiratory noises. I think 3 important noises you should know. Why I am telling is, if you hear that noise, you can localize the lesion. Stridor always say there is a problem in the extrathoracic compartment. Sometimes you can call it as upper airway. Wheezing always denotes intrathoracic compartment. That means it is also called as lower airway. Grunt is the one that shows there is an involvement of parenchyma, diffuse parenchymal disease. That is the reason why the child expires through the closed glottis, thereby increasing the end expiratory pressure. You should also know something about snoring, stutter, snuffles, rattle. Snoring everybody knows. It is a sound that happens in the sleep because of the vibration of the nasopharyngeal structures, whereas stutter is almost something like a snoring, but it is happened during awake. Mostly it is happening in a child neurologically compromised due to the pooling of secretions in the oropharyngeal area. Snuffles typically seen in young infants, newborn and young infants. It is because of the nasal crust, and rattle is sometimes it is a say bubbling sound. Some mothers say my child is having a lot of secretion in the throat, chest and all. So it is a chesty sound denoting some secretions. Before going to laryngomalacia, some very important point I want to share that. And what is the difference between stridor and wheeze? I already said stridor is due to the extrathoracic obstruction, whereas wheeze is due to intrathoracic obstruction. Which is the one that divides? Actually, some books divides this into a different way. The most important way that you can approach is, you all know trachea. The trachea traverses from neck to thorax. So that is why you can call it as sometimes cervical trachea and thoracic trachea. So you have to divide. I am telling about the imaginary line. You have to divide the trachea into upper trachea and lower trachea, and anything above that. See, for example, you make an imaginary line in the root of the neck, that is in the middle of the trachea. Anything above, that is a cervical trachea, larynx, supraglottic structures. All these things are all called as extrathoracic airway, and any partial narrowing or obstruction that causes a turbulent flow resulting in a stridor. That is a very noisy sound. That is what we are going to see here. And anything less than middle of the trachea, that includes lower part of the trachea, sometimes it is called thoracic trachea and bronchi, and any narrowing happens in the intrathoracic compartment causes sound, that is a musical sound, that is called wheezing. This is a very good slide I used to show repeatedly. If you approach stridor, I already said you can divide into acute and chronic. I already talked about the acute stridor. Now we will go on to the chronic stridor. Today's lecture I am going to confine myself to laryngomalacia. Probably in my future lectures I will show why I have divided, because I do want to show how the bronchoscopic view, or if you see what is happening in the laryngomalacia, it gives a more knowledge rather than reading a book and all. This is another way of classifying stridor based on the age. In neonates, most of the causes are congenital causes. That includes laryngomalacia, subglottic stenosis, subglottic hemangioma, vocal cord paresis, tracheomalacia. Tracheomalacia is very important cause, and that causes compression of the larynx from outside is a vascular ring. And I already talked about the all acute causes, and as I said, now we will go on to laryngomalacia. It is also called congenital laryngeal stridor. It is the most common cause. Let us go this clinical scenario. It is a 6 weeks child presenting with the inspiratory stridor. I already said stridor is always inspiratory because of the dynamics. I already explained in my acute stridor class. The child is presenting with a inspiratory noise, that is inspiratory stridor. And the mother says the stridor is increased in a supine position, particularly during the crying and feeding, but it appears to be normal. There is no sound during sleep. Or if the child is put him in the prone position, the sleep reduces. That is what the complaint. And there is no typical respiratory distress. Child is active, otherwise growing well and all. This is the thing. And anybody think this is a common differential diagnosis or laryngomalacia and acute laryngotracheobronchitis. Now I will show how the laryngomalacia looks in a bronchoscopy. I think this is off late. I think this is one of the child I have done recently, referred for a bronchoscopy because they feared it has been referred as a severe laryngomalacia and all. Can you see that I am going to show one structure, and what is that structure that comes and goes? Yes, that is what epiglottis. Actually, epiglottis is something here. The epiglottis looks little abnormal. It is a small, hypoplastic, curled. You can see that it is curled over its own. Then after this is not a little abnormal epiglottis. Sometimes they call it as a omega shaped and all. And this epiglottis also bedding over the glottis. I am not able to go because epiglottis is immature, and because of the flopiness, it beds over the glottis. Now I try my level best to go and see the glottis. Now I am rotating the bronchoscope, and I am able to see the structures below the epiglottis, that is a glottis. Slowly can you see that? And these are the structure. This is in front of the epiglottis is a vallicula. Here is now you are able to see that. Can you see the glottis? These are the arytenoids. I am telling you the points is arytenoids. Actually, look at the arytenoids. Arytenoids are very big, relatively big, and you can see the aryepiglottic fold also. Can you see now? It's very typical, very big arytenoids. There are two arytenoids, and whereas the aryepiglottic fold is appeared to be very, very small. These are the typical findings that goes with the laryngomalacia. Curled epiglottis, omega shaped epiglottis, short aryepiglottic fold, and also very big arytenoids prolapse. These are normal epiglottis. People, once you see that, you cannot forget. Epiglottis is a very big one. Sometimes you can see through the mouth also. If you have a throat examination, you can see the tip of the epiglottis also. And this is all normal. But what is happening in the laryngomalacia? In the laryngomalacia, actually laryngomalacia may be divided into three: mild, moderate, and severe. Most of the mild cases, you can say the epiglottis is abnormal, either a omega shaped or it may be I think curled on its own. All these things you can see that, and that is what I have shown that also. Coming to the laryngomalacia, laryngomalacia typically happens after 4 weeks, but anything that happens immediately after the birth, I am telling about the stridor. Laryngomalacia typically present with the inspiratory stridor after 4 to 6 weeks. But anything that happened before that, it is not laryngomalacia, because some other causes like a subglottic stenosis or vocal cord paralysis, they start very early. Somehow laryngomalacia, because of the immaturity of the supraglottic cartilages, and initially newborn period it becomes quiet because child appears to be very quiet. When the child become active, you can see the inspiratory stridor. So the point is, if the stridor happens at birth, causes are different. Maybe subglottic stenosis or maybe vocal cord. Whereas typically it happens after 4 to 6 weeks. You have to think of laryngomalacia. The commonest cause of it is one of the very, very common cause. If you look at the chronic stridor, the commonest cause is the laryngomalacia. It accounts around 75 to 80%. And I already said it is because of the immaturity and of the larynx, and all the supraglottic structures, particularly the epiglottis, arytenoids, aryepiglottic folds, all they are abnormal. And depending upon this abnormality, we divide laryngomalacia into mild, moderate, severe and all. And mild, moderate laryngomalacia is not a problem. Actually the child, his sound is very, very alarming, scary. Even when the child enters your office room, you can see the sound. Some child is waiting in the outside the office room also, you can see the sound and all, but it's really scary for the parents. But mild and moderate are appear to be it is not problem. But severe severe laryngomalacia is a very important one, because why I am going to tell about that. I already said in a laryngomalacia, all these structures, particularly the epiglottis, arytenoids, aryepiglottic folds, are abnormal. Epiglottis may appear very small, hypoplastic, as we already seen, omega shaped or curled, is bedding over the glottis. That is what we have seen now. Arytenoids appear to be prominent, and it also prolapse over the glottic opening, and that is what we have seen. And aryepiglottic folds appear to be very short, and it is also inward. All these things make during inspiration, it will go and sink into the glottis and make the child very difficult for normal breathing. Somehow mild laryngomalacia and moderate laryngomalacia, with the sound the child may able to grow normally. But severe laryngomalacia is a real problem. Why I am telling that, I will come about that why severe laryngomalacia should be given importance. I will talk little later. And coming to the treatment, most of the mild, moderate laryngomalacia, there is no only supportive therapy. Actually, you have to make the child calm, and if the sound is very, very big, the noise is very big, the stridor is very big, put the child on prone position. And most of this laryngomalacia child also have associated GOR. So sometimes they may benefit with the anti-reflex therapy, and slowly over the time that maturation of laryngeal cartilages appear, and most of the sound, most of the stridor, most of the child, they become normal by 2 years of age. And I talked about supraglottic severe laryngomalacia. Sometimes severe laryngomalacia needs some surgery, that is called supraglottoplasty. That is a very important surgery. And sometime before we have done very heroic measures like tracheostomy and all. Now everybody happy with this surgery, and this is only indicated in a severe laryngomalacia and all. I think this is a very interesting study we have done those days, and we pulled all our severe laryngomalacia child, and most of them, they have associated wheeze also. That is why we have done this study, why these children have noisy breathing, they stridor in addition to wheeze and all. To our surprise, and 48% of severe laryngomalacia child also have associated or synchronized airway anomalies, of which the most important is the tracheomalacia. I think this is very, very important. So mild laryngomalacia is normal, moderate is normal, severe laryngomalacia also they may live normal, but unfortunately child with a severe laryngomalacia, they have in addition to stridor, if they have associated V's, then you have to think of other associated lesion, of which the most important thing is the tracheomalacia, and that is what this study shows that. And hope you all enjoyed the one of the important cause of chronic stridor, laryngomalacia. Sometimes it is called congenital laryngeal stridor. And in my next talk, we'll start about in this series. I'll be show some bronchoscopic view also. In my next talk, we'll go to the another important topic. Particularly, I may be talking about either laryngeal web or subglottic stenosis or vocal cord paresis. All these things we'll discuss. Thank you very much.